Hi, I am Dr. Selvaraj, Professor of Surgery, Malakam Manipal Medical College, Malaysia. Welcome back to my series of surgical teaching videocasts. These are meant mainly for undergraduate medical students doing the surgical clerkship rotation. I promise you will become competent in clinical problem solving and surgical decision making if you are going to watch these videos over and over again. In this episode, I am going to talk on one of the important topics in general surgery, the colorectal carcinoma. This is one of the important causes for lower GI hemorrhage. So I am going to talk on the following subheadings. Going to talk on the causes of the lower GI hemorrhage, the epidemiology of colorectal carcinoma, the etiology, pathogenesis, clinical features, investigations, staging and prognosis, treatment, follow-up of colorectal carcinoma. Of course, I am going to include a MINDMAP and a diagnostic algorithm and a management algorithm. So coming to the various causes of the lower GI hemorrhage, okay, the massive hemorrhage is usually because of diverticular disease or angiodysplasia or AV malformation. So the other causes of lower GI hemorrhage are colorectal carcinoma, hemorrhoids, fissure in ano, ischemic colitis, inflammatory bowel disease including the ulcerative colitis and Crohn's disease, Meckel's diverticulum, and sometimes even the massive upper GI hemorrhage can present as lower GI hemorrhage, namely either melena or hematochezia. So this is our classical clinical vignette. Our patient is a 57-year-old obese man, is seen by his primary care physician for his yearly physical examination. He endorses a 20 kg weight loss in the past few months without changing his diet or exercise. He also reports pencil-thin stools and intermittent constipation. He feels that he cannot adequately evacuate his stools, and that is tenesmus. He has smoked 1 pack per day for the past 20 years. He has a history of type 2 diabetes. He has never had a colonoscopy. There was 2 episodes of bleeding per rectum. Family history is negative for any cancer. On examination, he is afebrile with a heart rate of 78 per minute and blood pressure of 132 by 74 millimeters of mercury. His abdomen is soft and non-tender. There was no abdominal mass and the abdomen is not distended. On rectal examination, there was no mass palpable without any blood in the finger stop. The laboratory examination reveals a hematocrit of 37%. So the normal is 40 to 52%. So with these clinical features, the patient has got a significant weight loss, unintentional weight loss, and he is passing a pencil-thin stool, that is low caliber stool with intermittent constipation. And there was history of tenesmus, and there was 2 episodes of bleeding per rectum, and there was abdominal examination, no mass, even rectal examination, there was no mass, but the hematocrit is slightly lower on the lower side. So with this clinical finding, you have to suspect left-sided colonic cancer because the patient is passing pencil-thin stool with tenesmus, and of course he is slightly anemic. So this provisional diagnosis should be confirmed by doing a colonoscopy where you can see the mass and you can take a biopsy as well. So what is the epidemiology of colorectal cancer? This is the second most common malignancy in United States with more than 155,000 new cases diagnosed every year. The incidence is highest in the industrial countries and it is more common in the elderly people. Women, this is the third most lethal cancer after lung and breast. In men, also this is the third most lethal cancer after lung cancer and prostate cancer. Regarding the site of the colorectal cancer, it is of course more common on the rectosigmoid area, but the incidence of cancer in the right colon as compared to the left is slowly increasing. So therefore, the screening should be of the entire colon and not just the rectosigmoid area alone. So this is regarding the site of the tumor. So this is more common in the rectosigmoid area. Almost more than 80% of the tumors are occurring in this area, and the right-sided tumor is only 20%. So this is the pie chart you are seeing. The rectum is the most common area, and then followed by the sigmoid. This is the rectosigmoid, constitute almost 80%. And then the right-sided thing, the cecum is 6%, ascending colon 3%, hepatic flexor 2%, transverse colon 5%, and splenic flexor is 3%. Descending colon also only 3%. So the most common site is the rectosigmoid area. Coming to the etiology of colorectal cancer, majority of these is controlled by genetics. So increased incidence in the first degree relatives of colorectal cancer patient, especially with ages less than 50 years. So number one is the familial adenomatous polyposis or FAP. The incidence is comprise only less than 1% of the total colorectal cancer. The gene responsible has been identified on the short arm of the chromosome 5. The condition is diagnosed when a patient has more than 100 adenomatous polyps in the colon. It is autosomal dominant. Polyps are usually visible on endoscopy by the age of 15 years, but the carcinomatous changes will take another 10 to 15 years to manifest. The another thing is hereditary non-polyposis colonic cancer. So this consists of 5 to 10% of all colorectal cancer. The other name for HNPCC is Lynch syndrome. The genetic abnormality is usually on chromosome 17 or 18, and this is also autosomal dominant in nature. The Amsterdam criteria says that there should be 3 or more relatives with colorectal cancer spanning over 2 generations, and one of whom is must be a first degree relative. 1 or more colorectal cancer cases diagnosed before the age of 50 years. So these are the 2 criteria to confirm the patient is having HNPCC or Lynch syndrome. So other pre-malignant conditions, or especially the IBD, the most common is the ulcerative colitis will form colorectal cancer more than the Crohn's disease. And the environmental factors also play a role, just like the diet, the fatty diet, and the exposure to chemicals like food additives, alcohol, ionizing radiation, and bile acids. All are risk factors for the patient to develop carcinoma. So coming to the actual pathogenesis, the development of carcinoma is a multi-step process. The mucosal epithelium progresses through a series of molecular and cellular events. Further genetic alteration results in high degrees of cellular atypia and glandular disorganization. The adenoma to carcinoma sequence is always associated with genetic changes, even in sporadic colon cancers. So this is the normal mucosal epithelium. So this will turn into a hyperproliferative epithelium because of inactivation of this APC gene. Then this hyperproliferative epithelium will turn into adenoma because of KRAS. This is the oncogen. So this activation of this KRAS oncogen will transfer the hyperproliferative epithelium into an adenoma. Then the deletion of P53. This is the tumor suppressor gene. If this is going to be deleted, then the adenoma will turn ultimately or eventually into a carcinoma. Coming to the gross pathology, so this, broadly you can divide the gross pathology into two types. Non-stenosing type that comprises the cauliflower growth. This is the cauliflower growth or the ulcerative growth. Both are non-stenosing type, whereas the first two are stenosing type, that is the annular variety and the tubular variety. The tubular variety, the stenose segment is a long one. So this will produce, if you are going to do a barium meal, this tubular variety will produce the characteristic apple core appearance if you are going to do a barium enema. The spread of the tumor may be local spread by the continuity along the bowel wall or by contiguity to the adjacent structures like retroperitoneal organ and the nearby structures. It can also spread through the lymphatics. So the lymph nodes are three types. The paracholic lymph nodes, which is lying in the immediate vicinity of the bowel wall, and then it can spread to the intermediate nodes. These nodes are lying along the ileocholic, right cholic, middle cholic or sigmoid arteries. And the apical nodes, these are situated around the origins of either the superior or inferior mesenteric arteries. So the nodes may be a paracholic nodes, intermediate nodes or apical nodes. The tumor can also spread through the bloodstream and it can metastase early to the liver, whereas the lower rectal cancer can bypass because the blood, this will be draining into the IVC, so it will go into the lungs, the lower rectal carcinoma. The clinical features, broadly you can divide the colorectal cancer into right colonic cancer, left colonic cancer and the rectal cancer. The right colonic cancer comprises only 10%. So these patients may be having either a mass or lump in the right ileal fossa, anemia due to protracted occult blood loss. There may be pyrexia of unknown origin. Sometimes there may be appendicitis when the carcinoma occludes the appendicular orifice. And of course, there will be weight loss, unintentional weight loss will be there. If it is a left colon carcinoma that comprises 30%, there may be pain in the left iliac fossa, which is referred to the suprapubic area. There will be alteration of the bowel habit. Either the patient may have either constipation or diarrhea. This is the most common symptom. There may be a palpable lump in the left iliac fossa. The patient also may have loss of weight, and characteristically, these patients will pass small caliber stool or pencil thin stool. In the rectal carcinoma, this consists of 60% of the cases, colorectal cancer. The characteristic symptom is the patient will be passing blood and mucus per rectum, and patient also will be having tenesmus or inadequate feeling of evacuation of the stool. They may also have sacral or perineal pain. Of course, these patients also will be having unintentional weight loss. So coming to the investigations, you can do the laboratory studies that includes hemoglobin and hematocrit, fecal occult blood tests, liver enzymes or liver function tests. You can also do carcinoembryonic antigen, which is a tumor marker for colorectal cancer. You can do a sigmoidoscopy, both rigid and flexible. Rigid sigmoidoscopy you can use without preparing the bowel. You can do even in an emergency setup. You can do a rigid sigmoidoscopy, whereas for a flexible sigmoidoscopy, you have to prepare the large bowel. Colonoscopy is also necessary to confirm the diagnosis and to exclude any synchronous lesions in the proximal part of the colon. You can also do a double contrast barium enema, which will characteristically that will show a apple core appearance if the tumor is an annular variety. You can also do endorectal ultrasound. Information regarding the depth of invasion into the bowel wall by a rectal tumor and involvement of the lymph nodes you can assess by doing this endorectal ultrasound. Of course, you must do a CT scan to rule out any secondaries in the liver. This is CT scan of both chest and abdomen and even the brain to rule out any secondary in the liver, any secondary in the chest or any secondary metastasis in the brain. So in this picture, you are seeing, this is a colonoscopic picture. You are seeing a tumor in the colonic area, and this is virtual colonoscopy, or this is called CT colonography. This also where we need not actually need the colonoscopy instrument. CT, okay, the computer will generate this picture. So this is also very accurate, but this is only diagnostic. You cannot do any therapeutic procedure in this virtual colonoscopy. So this is the barium enema, where you are seeing the characteristic apple core appearance. So here this is the annular variety of colonic carcinoma, where you will get this apple core appearance. This is very characteristic of colonic cancer. Here in this picture, this is a CT of the abdomen, where you are seeing multiple secondaries spread all over the liver. So this picture is a CT of the abdomen where you are seeing a cecal carcinoma. This is an endorectal ultrasound, where you are seeing the rectal carcinoma is, okay, it is going out of the rectal wall. So going out of the rectal wall. So this is almost stage 4. So here you are seeing two MRI pictures, where in the left side you are seeing a T3 tumor that is invading the mesorectum. Here you are seeing endoluminal stent. In an inoperable case of sigmoid carcinoma, okay, if it is inoperable, okay, you can put a stent inside. So coming to the staging of colorectal cancer, the old classical staging is called Duke's classification. So this ABCD, Duke's A means invasion into but not through the bowel wall. Duke's B, invasion through the bowel wall but not involving lymph nodes. Duke's C is involvement of the lymph nodes, and Duke's D is widespread metastasis. But nowadays we are using this modified Osterkoller classification. So in this classification, stage A, the tumor is limited to the mucosa. You can see that. So this is the mucosa. The tumor is limited to the mucosa. In stage B1, okay, it is extending into the muscularis propria but not penetrating through its nodes are not involved. So this is what the B1. In B2, okay, it is penetrating through the muscularis propria, nodes not involved. This is here also it is penetrating through the muscularis propria, but nodes are not involved. In C1, it is extending into the muscularis propria but not penetrating through it, but nodes are involved. That is, it is not penetrating through the muscularis propria, but nodes are involved. So this is C1. Whereas in C2, okay, it is penetrating through the muscularis propria and nodes are also involved. So that is C2. And the D is distant metastasis, either to the lung, liver, bone, or even the skull. So this is all methods of classification you can see in this tabular column. So this is the TNM classification. This is UICC staging, and this is the modified Duke's staging. And here you can see the prognosis or the survival rate also. So if it is stage 0 means that is in TNM stage, it is only dysplasia. So stage 1 or stage A in modified Duke's, the tumor is invading the submucosa. Tumor invades muscularis propria, that is T2. No lymph node metastasis. So survival in this group is 85 to 95. So stage 2 or grade B in Osterkoller, the tumor invades beyond the muscularis propria. Now it becomes T3. Tumor invades into the other organs is T4. The no lymph node metastasis. So in this group, the survival rate is 60 to 80%. Stage 3 or grade C. So this is in TNM, it is 1 to 3 regional lymph nodes involved and any T. So that is N1. So 4 or more regional lymph nodes involved and any T, it is N2. And there is no distal metastasis. Whereas in C grade, that is C1 is apical node not involved, and in C2 apical nodes are involved. So in this group, stage 3 or grade C, the survival rate is only 30 to 60%. In stage 4, in TNM stage, there will be distant metastasis, that is M1, any T or any N. So this is in modified Osler-Collar-Dukes classification, it is grade D. So the survival rate is only less than 10%. So coming to the treatment of colorectal cancer, if it is carcinoma of the right colon, you must do radical right hemicolectomy. If it is carcinoma of the hepatic flexure or the right side of the transverse colon, you have to do radical extended right hemicolectomy. If it is carcinoma involving the transverse colon, you must do radical transverse colectomy. If it is carcinoma of the left colon, you have to do radical left hemicolectomy. If it is carcinoma of the sigmoid colon, you must do radical sigmoidectomy. If it is carcinoma involving in the upper third of the rectum, you have to do high anterior resection where the tumor will be more than 15 centimeters from the anal wedge. If the carcinoma is situated in the lower third, one third of the rectum, you can do low anterior resection if the tumor is situated more than 8 centimeters from the anal wedge, or you can do abdominoperineal resection with total mesorectal excision if the tumor is situating only 6 centimeters from the less than 6 centimeters from the anal wedge. Suppose if the patient is presenting with acute obstruction as an emergency case, you should do only Hartmann's procedure. You can excise the tumor, but you cannot do, you should not do a primary anastomosis, because if you are going to do a primary anastomosis in an emergency situation, the leakage from the anastomosis is more likely. So you should not do it. You have to do only Hartmann's procedure, where the distal end of the bowel will be closed and kept inside the peritoneal cavity. The proximal end you have to bring out as a temporary colostomy. That is what is called Hartmann's procedure. So here in a diagrammatic representation, if it is a colonic CA over the either in the cecum or in the ascending colon, you have to do a radical right hemicolectomy. Radical means you have to remove the paracolic and the intermediate nodes. Both you have to remove. You need not remove the apical nodes in a radical surgery. So here if it is in the hepatic flexure, you have to do radical extended right hemicolectomy. If it is in the transverse colon, do a radical transverse colectomy. If it is in the left side colon, then you have to do radical left hemicolectomy. If it is in the sigmoid colon, do radical sigmoidectomy. So if it is in the upper part of the colon, that means the tumor is lying say more than 10 to 15 centimeters, then you can do anterior resection. This is again divided into high anterior resection and low anterior resection depending upon the level of the tumors from the anal wedge. So here you are seeing how they are after resection you can do an anastomosis with the aid of end-to-end anastomosis stapler, or this is called EEA stapler. You are seeing an anvil here, so you have to introduce through the anal canal, bring the proximal normal colon, and you have to anastomose with the distal bowel. Either you can do a colo-anal anastomosis, or you can create a pouch and pouch anal anastomosis also you can do with the aid of this EEA stapler. And here if the tumor is very near to the anal wedge, say within 5 centimeters from the anal wedge, then you cannot do this anterior resection. Then you have to resort what is called abdominoperineal resection and AP resection. Here you are seeing the perineal part of the AP resection, and patient will be eventually having an permanent end colostomy. So the follow-up, most tumors recur in the first 2 years after curative resection. Colonoscopy and barium enema are done in the post-op period to establish a baseline. Colonoscopy is repeated annually for 4 years, and then every 2 to 3 years. CEA level is done every 2 months for 2 years, and then every 4 months for another 2 years. Then it should be done annually. CEA level is a sign of recurrence. If it is abnormally elevated, you have to suspect some recurrence. You must do chest X-ray also every 6 months for the first 3 years. Then you have to do it annually. You must also do complete blood count, liver function test, and both should be done every 3 months for the first 2 years, then every 6 months for the next 2 years, and then you should do it annually. So this is the mind map for colorectal carcinoma. The etiopathogenesis is okay. This is the FAP or HNPCC, or it may be environmental factors like chemicals or diet, and activation. Mainly it is activation of the oncogene and inactivation of the tumor suppressor genes. That is the cause for the development of adenoma to carcinoma sequence. Clinical features: right colon will present with anemia, lump and fever. Left colon will present with constipation, diarrhea, bleeding fear, and weight loss. Whereas rectum, there will be bleeding fear, tenesmus, and narrow caliber stool. Investigations: you can do fecal occult blood or direct digital rectal examination. You can do and confirm the, especially in rectal carcinoma, you can do this digital rectal examination. And you can do sigmoidoscopy, either rigid or flexible. You can also do a colonoscopy or CT colonography or the virtual colonoscopy. You can take a biopsy in the actual colonoscopy and you can confirm the diagnosis. You can also do a double contrast barium enema, which will show the characteristic apple core appearance in case of annular variety of cancer. You can also do endoluminal ultrasound to find out the status of the rectal cancer invasion. The degree of invasion you can do by doing this endoluminal ultrasound. Of course, you must do CT of both abdomen, chest and brain to rule out any metastasis in liver, lungs or in the brain. So staging, it is mainly the Duke staging or the modified Ostler-Koller Duke staging. So coming to the prognosis, if it is stage 1 or grade A, the prognosis, the 5-year survival rate is 85 to 95. If it is stage 2 or grade B, the survival rate is 60 to 80%. If it is stage 3 or grade C, the survival rate is 30 to 60%. If it is stage 4 or grade D, the survival rate is less than 10%. Coming to the treatment, if it is right colon CA, you must do radical right hemicolectomy. If it is hepatic flexure CA, you should do radical extended right hemicolectomy. If it is a transverse colon carcinoma, you must do radical transverse colectomy. If it is left colonic CA, you must do radical left hemicolectomy. If it is sigmoid colon CA, do radical sigmoidectomy. Upper and mid rectum, you can do either high or low anterior resection. If it is lower rectum CA, you must do AP resection. In emergency scenario, you can do Hartmann's operation only. Suppose if the tumor is inoperable, then you can put a stent inside, and if the nodes are involved, you can give chemotherapy also. But in colonic CA, there is no role for radiotherapy, whereas in rectal CA, you can give what is called neoadjuvant radiotherapy to downstage the disease. That you can do only for rectal CA and not for colonic CA, radiotherapy. Yes. So this is the diagnostic algorithm, that is the rectal bleeding. You have to do a thorough history and physicals. If the patient is passing bright red color blood, then better you do proctoscopy and sigmoidoscopy to rule out any rectal cancer, polyp, hemorrhoids or fissure. Suppose if the proctoscopy and sigmoidoscopy is normal, or the patient is passing dark red blood, then you can do colonoscopy or barium enema, where by doing this procedure you can pick up a polyp, the cancer of the colon, inflammatory bowel disease like ulcerative colitis or Crohn's disease or diverticular disease. Suppose apart from passing dark red blood, if the rate of bleeding is very profuse, very brisk, then you have to do an upper GI endoscope or arteriogram or RBC TEG isotope scan, where you can pick up angiodysplasia, Meckel's diverticulum or even the peptic ulcer. So this is the treatment algorithm for colonic cancer. I think I have already talked about this. This is the thorough history and physical. This is what is called the colon screening, where you can do the fecal occult blood test, flexible sigmoidoscopy and colonoscopy. So I request my viewers to pause the video and just read all these things, because I've already discussed all these things in the previous slides. So this is a slide for carcinoma of the rectum and anus. This also you can pause the video and you can go through the various procedures, because this is also a treatment algorithm. So thank you very much for watching this video. If you think that these videos are very useful, I request all of you to do 3 things. First, you can like this video by clicking this symbol, or you share this video in your social media, or if you have not subscribed for this channel, I request you to kindly subscribe for this channel. So I thank you once again for watching this video. Let us meet in yet another video. Until then, bye bye.